So good evening everyone. I am Dr. Ankit Pandey. I am Assistant Professor in the Department of Respiratory Medicine here, and today I will be taking a lecture on the newer advances in the diagnosis and treatment of pulmonary tuberculosis. So I will be taking my topic under certain in this outline. First we will be learning about the National Strategic Plan 2017 and the NTP strategy which we are taking. We will see various diagnostic algorithms which are there for the treatment of tuberculosis. We will see the skin prick test, including the newer one which is called the CTB. We'll be getting to know what is CBNAT, what are the molecular assays, and the role of serology and the IGRA in the treatment of tuberculosis. We'll be seeing what is the scientific basis of treatment of TB and what are the newer definitions. We'll see the role of steroids and pyridoxine in the treatment of pulmonary tuberculosis. We'll see what are the newer weight bands which are there in the NTP now and what happens when the weight of the patient changes. We'll be seeing about the isoniazid preventive therapy and where exactly do we use isoniazid preventive therapy, and we'll see what is the follow-up of pulmonary tuberculosis patient looks like. So our Prime Minister is going to address the World TB Summit tomorrow. Actually about the same thing. It's one of the major health and economic thing for our country to eliminate tuberculosis as soon as possible. So what is the National Strategic Plan 2017 to 25? It is to achieve a 90% notification rate for all the cases. It is to achieve 90% success rate for all the new and 85% for all the retreatment of tuberculosis cases. It is to significantly improve the successful outcomes of treatment of drug-resistant tuberculosis. Specifically, it is to achieve decreased morbidity and mortality associated with HIV. So HIV associated with TB, there should be decreased mortality and morbidity, and to improve the outcomes of TB, especially in the private sector. So what is the NTB strategy? We are actually aiming to go 5 years before what is the global targets are like. So for us, the vision overall is a world free of tuberculosis, where there are zero deaths, disease and suffering due to tuberculosis. That is a bit far away, but we still can aim for it. Our current goal is to end the global tuberculosis epidemic, and for that we have certain indicators and milestones which we have to reach by 2025 according to our Prime Minister. So the reduction of number of TB deaths compared to 2015 should be at least 75% by the year of 2025. The reduction in TB incidence rate should be by about 50% by the year 2025, and there should be zero families which are affected or losing catastrophically economically due to tuberculosis. So what is the diagnosis? How do we diagnose TB and quality assurance? Who is a presumptive pulmonary TB case? It refers to a person with any of the symptoms and signs suggestive of TB, including cough for 2 weeks or more, fever of 2 weeks or more, significant weight loss, hemoptysis or any abnormality on the chest radiograph. So TB is one disease where there is any abnormality on the chest radiograph entails to be a presumptive TB. Now what are the other presumptive PTB causes? See, any contacts of a microbiologically confirmed pulmonary tuberculosis should be considered to be presumptive TB in itself. Any suspected or confirmed extrapulmonary TB having cough of any duration should be considered to be an should be considered to be a presumptive TB case, and any HIV positive patient having cough of any duration should be considered to be a presumptive TB case. Now the screening, we know for every patient who we assume to have tuberculosis, we need to get a smear examination done for a microbiological confirmation and a chest X-ray. And now according to the latest guideline, every patient who is confirmed to have tuberculosis should know about his rifampicin resistance status or not. So everyone should get a CBNAT done before starting treatment, or at least by the end of a few days we should get the CBNAT results as to determine whether the patient is MDR or not. So EPTB algorithm almost goes more or less the same. The only thing is if the sample is less or it's a pressure sample, we should much rather go for CBNAT analysis, which is more sensitive and a better investigation than the ZN staining. So that is the only difference there. Now, what is the skin test like? What is the use in India? Now, skin prick test has a very limited use in India. It can be used as an adjunct tool in a diagnosis of TB only among children, not in adults. The current recommendation is to use 2-tuberculin PPD RT23 for all diagnostic purposes. A skin prick test is considered positive if the induration is more than 10 mm in an immunocompetent host and more than 5 mm in an HIV co-infected person. It may be noted that currently there is no standard PPD available in the country, but a new skin prick test that's called CPTB that is from the Copenhagen strain, is likely to be available by the end of this year most likely, and this will be equivalent to the sensitivity of IGRA, that is interferon gamma assay. So what is CTB mostly like? The results are coming very optimistic from the group 3 trials, and it's safe, easy to use, and is comparable to the accuracy of IGRA as I have already told. It actually measures the body's immune response to ESAT6 and CFP10, the same antigen we use for IGRA. Now CTB uses a universal 5 mm or larger in duration to identify TB infection among all patient groups. So unlike the other tests like MANTO and all, where we had a different 5 mm and 10 mm for different immunocompetent and immunocompromised people, here there is a standard 5 mm in duration for both. There is another actually good thing about it. The BCG infected, BCG immunized patient will not be falsely positive in this test, which are usually positive in the MANTO test. So it combines the simplicity and the low cost of skin testing with the diagnostic accuracy of IGRA. So they are both based on the same purified ESAT6 and CFP10 antigens. And the trials, as I have told you, TSAT and TSEC 01 to 06 trials have all been very optimistic, and we are very soon gonna get this in our setup. Here there is a diagrammatic representation of the same, where we can see that CTB, an optimal cutoff of 5 mm, usually more than enough to determine the latent tuberculosis, but still not there for the treatment of tuberculosis or as a diagnostic tool. It's only used as an adjunct, that too in children less than 5 years of age. So the conclusion is CTB results correlate with exposure to Mycobacterium tuberculosis. CTB and quantiferon tests have both similar positivity rates. CTB is only impacted by HIV infection with low CD4 counts, that is less than 100. Otherwise, it is almost same in even immunocompromised people. CTB duration size is impacted by young age on a level with PPD. CTB deliver IGRA-like performance in the field-friendly skin prick test format. Now, IGRA is the same. It is an interrogate effector T cell responses to two immunogenic mycotuberculosis antigens, that is 6 kilodalton early secretory antigenic target ESAT6 and 10 kilodalton culture filtered protein, that is CFP10. And it can also be affected by only a few atypical mycobacteria like Mycobacteria marinum or Kansai, but not present in the BCG vaccine, as I have already told you. However, these tests are expensive, they require phlebotomy, so we do need the patient's blood, which is not the case in the skin prick test like CTB. So interferon gamma is done in actually multiple ways. There are two main ways which we are doing. One is a interferon TB gold in tube test, and one is a TB spot T-spot test. The quantiferon gold is 3 specialized blood culture tubes are actually used. One is the grey, which is a negative control. So there should be no immune response to the antigenic grey control tube. Red is for the tuberculosis antigen and purple is for the mitogenic control. So to a normal mitogen, we should elicit a response. So that is what the purple tube is for. So immediately after blood collection, all tubes of blood must be vigorously shaken 10 times to ensure the entire surface of the tube has been coated with blood. Appropriate mixing is essential to ensure antigens emitted in the tube walls interact with the blood, and the tubes must be incubated for 16 hours at 37 degrees Celsius for 16 to 24 hours. After incubation, an enzyme-linked immunosorbent assay ELISA is performed on separated plasma using specifically designed quantiferon GIT microwell plate. So these are the pictographic demonstration of all these things. What are the shortcomings? Common clinical reasons for indeterminate result include relative energy and immunosuppression, mostly extremes of age, active infection, or even antimicrobial treatment prior to taking these tests. Technical reasons for indeterminate result include prolonged transit time after the draw of blood and incubation, insufficient mixing of the blood, and incomplete washing of the ELISA plates. TB spot test. For the T spot test, whole blood is collected in lithium heparin or sodium citrate anticoagulated tubes holding 8 ml of blood. After blood is collected, sample should be processed within 8 hours of collection unless processed with T cell X and reagent, which extends the hold time to 32 hours after vein puncture. So what is CBNAT? This is the most effective tool we have right now. With the availability of Gene Expert Ultra cartridge in the near future, the reconfirmation of RR-TB among new TB patients will no longer be needed. Or if absent indeterminate error or no result, we'll get an additional CBNAT and get done to get valid result. And in case of indeterminate or second occasion, an additional sample would be collected and sent to the nearest intermediate reference laboratory (IRL) or culture and drug sensitivity test for LP and liquid culture. All key populations like people living with HIV, children, EPTB will preferentially offered upfront CBNAT rather than waiting for the culture or the AFD staining. We'll directly go for the CBNAT analysis. Now, what is the difference between Gene Expert and Ultra? So, in Gene Expert, we have a lot more antimicrobial content which we need for it to turn positive rather than Ultra where even less than or approximate to 25 bacilli are usually actually adequate. Now, what are the other molecular assays? The most widely used, evaluated and used assays are the line probe assays. We already know. So, we check for the resistance to rifampicin and INH. So, rifampicin RPO B gene and CAT-G and INH A gene for INH. And for XDR tuberculosis, GUIDE A and GUIDE B gene for the for chloroquinolones and RRS for the injectables like amikacin and kanamycin. So, what is the role of serology and IGRA? There is no role for inaccurate and inconsistent diagnostic like serology or IGRA right now in the Indian setup. Currently, there is no role, and the government of India issued a gazetted notification via 7 June 2012 that banned the manufacture, distribution, and use of correctly available commercial serological tests for diagnosing TB. Now culture MGIT 960 culture, though highly sensitive and specific method of TB diagnosis, require 2 to 8 weeks to yield results and alone does not help in the early diagnosis of treatment, though it still remains the gold standard for the same. An antibiotic trial of 7 to 8 days of amoxicillin and amoxicillin can be given, though antibiotics which have antimicrobial property like linezolid or clonazepam should be avoided. Okay.